Hello friends, like my previous video in which I had talked about first trimester screening of aneuploidies, today we'll be talking about second trimester screening of aneuploidies. So welcome to Medimantra, stay tuned to my channel, see the entire video, and if you like it, kindly subscribe my channel. Now we'll be discussing about second trimester aneuploidy screening. In my previous video, I had discussed about first trimester screening, whereby we have discussed about combined screening, dual screening, and the NT-NB scan, which we generally do at 11 to 13 plus 6 weeks. Now in this video, we'll be talking about second trimester aneuploidy screening. So for second trimester aneuploidy screening, we basically have a triple test and a quadruple screen. So triple screening and quadruple screening, of which triple screen has a sensitivity of around 65% and quadruple screening has a sensitivity of 75%. So tests which have sensitivity less than 75% are generally not recommended. So triple screen is generally not recommended in modern day obstetrics. It is recommended that if a second trimester patient comes to you for aneuploidy screening, you better get quadruple screen done. Now in triple screening, what all markers do we have? In triple screening, as the name goes by, you have three markers. One is maternal serum alpha fetoprotein. The second one is unconjugated estriol E3, and the third is your free beta HCG. So you see, if you have H in it, H if it is present in the name, then this will be raised in Down syndrome or trisomy 21. If there is no H, then these markers will reduce in Down syndrome. So how much reduce and how much increase? We will measure it by multiples of median, as we had seen in previous video. So this is very important. Maternal serum alpha fetoprotein, if it is less than 0.7 mom, then it is significant for trisomy 21. If unconjugated estriol is less than 0.8 mom, then it is significant for trisomy 21. And free beta HCG, if it is more than 1.8 mom, then it is significantly having risk of trisomy 21. Similarly, when you go for quadruple screening, you add one more marker, serum analyte, into it, and that is your inhibin A. So inhibin A also has H in it. So inhibin A also rises if there is trisomy 21. If it is more than 2 multiples of median, then it has significantly increased risk of trisomy 21. So till now it is very much clear what all serum analytes we do. So after that, one thing I want to stress upon over here. I want to say that depending upon country to country, there can be various screening protocols. So what are the various protocols which we follow in various countries? Number one is your integrated screening. Integrated screening protocol. The second is your sequential screening protocol. Sequential screening. Sequential screening can be of two types. Either it can be stepwise sequential screening, and second it can be contingent sequential screening. In integrated screening, what do you mean by integrated screening? If you follow this protocol, then every patient should undergo a first trimester screening for aneuploidy as well as second trimester screening for aneuploidy. So after the first trimester screening has been done, we will not disclose the report to the patient. We will ask all patients to undergo second trimester screening as well, and then we will get the reports. We will combine both the reports and give the final risk to the patient. So this is integrated screening. It is usually done in high resource countries like USA. ACOG recommends both first trimester as well as second trimester screening to all patients. Now let us talk about stepwise sequential screening. In stepwise sequential screening, all patients undergo first trimester screening. In first trimester screening, better to get a combined screening done because it has a high sensitivity of around 92%. Now based on this, there can be three type of reports. Either it can be low risk, intermediate risk or high risk. As I had told in my previous video that low risk means risk is less than 1:1000. Intermediate risk is 1:250 to 1:1000, and high risk is risk more than 1:250 in Indian setting. If it is low risk and intermediate risk, these patients undergo second trimester screening in the form of quadruple marker. And if it is high risk, then they directly go for chorionic villus sampling and decide for whether MTP has to be done or not. Now, patients who are already high risk in first trimester, we are saving their money. They need not to get a second trimester screening done and then go for amniocentesis. They can directly go for CVS and then decide whether to do MTP or not. Patients who have low risk or intermediate risk get a second trimester screen done, which can be either low risk, intermediate risk or high risk, and then decision has to be taken accordingly. So it is more economical than your integrated screening. Now, the most economical technique which is followed nowadays in Indian setup is the contingent sequential screening. So, contingent sequential screening is done like this. We get first trimester screening done for all patients, that is combined screening, you get it done. It can be either low risk, intermediate risk or high risk. Now most of our patients come in the low risk category. So these patients need not to do a second trimester screening. They can directly go for level 2 ultrasound and then do accordingly. Patients who are high risk, they directly go for chorionic villus sampling and decide for whether MTP has to be done or not. Patients who are intermediate risk in first trimester screening, they are the candidates who have to be undergone second trimester screening in the form of quadruple marker. Now this quadruple marker will either categorize into either of the three. If it is high risk, then go directly for amniocentesis and then termination of pregnancy. If it is low risk, then nothing has to be done. If it is intermediate risk, then you have to combine it with ultrasound findings of level 2 to get the final risk. Now whatever you get from the serum analytes, the final risk calculation from serum analytes is called the a priori risk. Very important. Always remember this. A priori is a single word, but you have to write it separate. So a priori risk is the final risk from serum analytes. It depends on which type of screening modality you are doing. Whatever is the final from the serum analytes is your a priori risk. We combine the a priori risk with likelihood ratio. Now what is likelihood ratio? Likelihood ratio is a ratio or risk stratification which we get from level 2 ultrasound. So in level 2 ultrasound, there are few markers which are called soft markers. Each soft marker has a positive likelihood ratio and a negative likelihood ratio. So each positive likelihood ratio and negative likelihood ratio has to be multiplied with the a priori risk to get the final risk. So this is very important. Whatever risk stratification you have got from serum analytes till now, combined screen or quadruple marker, that you have to multiply with the positive and likelihood ratio of each soft marker which you get in level 2, and then you get the final risk. So it is very important, if the soft marker in the ultrasound is absent, then you have to multiply the negative likelihood ratio. If they are present, then you multiply all the positive likelihood ratios and you get the final risk. So this is how second trimester aneuploidy screening is done. I hope you have understood it. If there are any doubts, you can message or you can leave comments on the chat box. We will try to improve our videos accordingly and bring you with more important and informative videos. Thank you so much.